Good morning. Good morning.
Hi, Derek. Good morning. Mohammed. Hi, Felix.
Mohammed,
Ben.
how are you?
Fine, thanks. Nice to have you in Egypt online. I hope the next time you will be in person here.
Yeah, thank you for having us. Should we start with a brief presentation of the patient?
Yes, please.
Okay. Also, very warm welcome from the whole Kiel team. So we are very happy to present a valve and valve case today. So we are having here an 81-year-old female patient. She has already undergone aortic valve replacement, surgical aortic valve replacement 5 years ago. She has received a rather small bioprosthetic valve, a Hancock 2 prosthesis in 21 millimeter diameter. And she also had full revascularization at that time point. So we have an early degeneration of the valve. The mean gradient is 47 millimeters of mercury. And the revascularization is still patent and the left ventricular function is good. What we're going to do is that we are aiming to implant a Medtronic Evolute R prosthesis, 23 millimeters, and we will post-dilate the prosthesis with a non-compliant balloon. And what we have also done is, you might see it on the right upper part of the monitor, we have brought a sentinel device in position in order to prevent cerebral emboli. Any questions from your side? Otherwise, we would directly start with the procedure.
Yes, Derek, maybe I'll start with the first question. Why did you decide for the Evolute, not for the Sapien, for example?
So it's a very, very, very small valve. The true inner diameter is about 70 millimeters. It's not a truly modifiable biological valve prosthesis, but as you will see in a second, Mohammed, you know that, it's at least a little bit modifiable. So we will use very high pressures in the post-dilatation in order to gain a little bit diameter. So you will see that. And the Evolute R, we think that the Evolute R is the valve which has, in this context, optimal hemodynamics. That's the reason why we are choosing the Evolute. When it comes to anatomy, there is enough space behind the bioprosthetic valve to implant the Evolute R. And we have patent bypasses, so no issues with coronary problems.
Hello. This is Mohammed Sobhi from Egypt. I know that nowadays we have a lot to do with the valve-in-valve. We have a lot of articles, a lot of patients' experience. But we have to know from you which type of leaflet modification you are going to do and how to decide this. Because there are several types already in and others are ongoing. So how can you decide this to the audience?
Excuse me, which kind of modification?
The leaflet modification.
I didn't get that sentence.
Yes.
Which kind of modification?
Yes. Yes.
Okay, yeah, so in this context, we are not going to do any leaflet modification because the Hancock 2 is a rather benign valve when it comes to valve and valve procedures. So we don't think that a leaflet modification is necessary. But of course, there are other types like the trifecta with the biological material being on the outer side of the valve frame. Then it might be important. But in this case, no leaflet modification, just post-dilatation.
Dr. Sobhi means about coronary obstruction, basilica, for example.
Yeah, sure, but not in this case, not necessary. So in this case, we are not going to perform any leaflet modification because we feel that it's safe to do the procedure without leaflet modification, so without any basilica-like techniques.
Thank you, Dirk. You can go on.
Okay, so we start. So as you might see, we have prepared already the access. We have performed ultrasound-guided access on both groins, so both femoral arteries have been already punctured with sheaths in place. Also, a permanent pacemaker, as you see, is in place. Also, a pacemaker for rapid pacing. So we will directly start to bring the big sheath in place. therefore, we are going to use a stiff wire. We had decided in this context to use the confida wire, and then we will exchange the 8 French sheath, which is currently in place in the right femoral artery, for a 14 French centrin sheath. It's actually a placeholder in this context, but we'll use it later. We'll use it later for the post-dilatation again. Just a minute. We have already the implant view with
actually we can't see anything. Sorry, we see only the monitor. We can't see your.
Only the monitor. Okay.
Yes, only the monitor.
We'll try to bring the camera a little bit better in position. Du müsstest da einmal zur Seite gehen, vielleicht auf die andere Seite. Okay, sonst ein bisschen in den Hintergrund. Vielleicht kommst du noch ein bisschen näher zu mir rüber. Okay, we'll try to improve the view. Könnten Sie den Monitor ein bisschen, also die Kamera ein bisschen rübernehmen? Ja. So, es drückt einmal in der Leiste. Haben wir genug Lokale? So the femoral axis was actually free and wide open, so no issues when it comes to sheath placement.
Hello, good morning. I'm Lino Patricio. I'm from.
Good morning.
Good morning. I'm from Portugal, and I was invited to be here in Cairo. Good luck for you. And my question is regarding you use the Evolut R and you didn't use the FX. Do you have any reason for this? And the second question is about the protection, cerebral protection. Do you use in every case of valve-in-valve, or use in this case particularly?
So I start with the second part of the question first. As you know, there is no significant data when it comes to cerebral protection. So what we do is that we use cerebral protection in cases where we believe that there is high risk for a cerebral embolism, and that's valve-in-valve procedures, for instance. We use it in every valve-in-valve case when the sentinel is suitable. When it comes to the valve type, we think that the Evolut R, without any skirt or something, with any modification, in a valve-in-valve context, especially in the Hancock 2, is the perfect valve. There's no need for any other features which is part of the newer generation valves like the Evolut FX. So in our hands, I feel that it's a perfect valve for such a procedure. Hörst du auch? Kannst du auch sprechen? Mach mal, ich kurz für mich gerade.
So, we didn't see the procedure till now. Could you focus on the screen, please? Hello? Do you hear me?
Yes.
Could you focus on the screen, please? We didn't see anything.
I think the camera goes on your legs. So can you fix the camera on the table itself and part of the camera to the screen if you have only a rotating camera?
Disconnected.
Proctor connected.
So it's a very tight valve, as you might see. Currently, we are working with a uncoated stiff steel wire, but I will exchange for a coated Terumo straight-tipped wire in a second. Left.
So till the signal come back, this is a live transmission for a patient who is 81 years old. He had surgical bioprosthetic aortic valve 5 years ago, and this valve is degenerated. So now they decided to do valve in valve, and they did the measurements, and they will select a Vidiot R23 for this procedure. So we're waiting for the signal again to see the whole procedure, inshallah.
Can I ask you, Muhammad Saad, in your experience in valve and valve, you pre-dilate or rupture the balloon and then put the valve and then post, or you just put the valve and then post-dilate?
Thank you, Dr. Sobhi, for your question. Both methods are acceptable, but in our center, we usually implant the valve at first and do post-dilatation. In our opinion, this may be more convenient for the hemodynamic, that you don't have any drop in the hemodynamic before implanting the new valve from one side. From the other side, maybe disruption of the leaflets may cause stroke, and that's why we use with every patient with valve-in-valve cerebral protection device.
Hamad, do you have any preference for the type of the valve, for valve and valve? I mean, what is the percentage of selecting balloon expandable versus self-expandable for valve and valve?
This depends mainly on the type or the size of the implanted valve and type as well. If you are a valve you can break, I think the type of the TAVI valve wouldn't be that important for the hemodynamics, because if you have a well-expanded sapien in a fractured valve, I think the hemodynamics will be good as well. If you have non-fracturable valve, like this case, this is the Hancock 2, I think the supraannular position of the valve like Evolute would be too much better than having an intraannular valve with constricted leaflet movement.
Do you have any precautions in sizing of the valve as the position regarding the coronaries, the septum? Is any difference or the same like for the CT findings, like the original valve inside the native valve?
This is a very important question. There are extra measurements to be done on valve-in-valve and TAV-in-TAV, like having the VTC, virtual valve to coronary distance, which is very important to predict coronary obstruction after implanting TAVI valve as valve-in-valve. And if you have some queries about having coronary obstruction, then you have to proceed for coronary protection, either Gemini technique or Basilica technique.
So,
das ist hintere Klappe, aber da komme ich in den Jet. Hast du gesehen? Da bricht da so ein bisschen, der Jet wirkt exzentrisch. Jetzt wird es da die Außenwand treffen. Dann heißt, müssen wir irgendwie unter durchkommen.
Ja.
Okay.
So now we see the screen now.
Und als nächstes hätte ich gerne einen rechten.
Dirk, we are back.
Ja, aber dann kommt der Winkel schlecht. Ist das? Ich komme dann zu steil runter.
Dr. Muhammad, if you have difficulty to pass the the valve. What's your tips and tricks to pass the surgical valve using Terumo wire or another catheter, or what's the tips and the tricks to pass the surgical valve?
We use the same procedure like native valve. We use Amplatz Lift 1 and a straight wire. Maybe you can try with pigtail as well to be sure that you are going through the annulus of the surgical valve, and if you have any dehiscence, that you are not through the dehiscence beside the valve. But I think using the usual way, Amplatz Lift 1 and a straight wire, either Terumo or non-Terumo, would be convenient.
Okay, so it's something, sometimes it's very difficult to pass the surgical valve. So we use the standard technique, and if it failed, we can use another catheter, Amplatz 2, or using Terumo wire. It's something passing the surgical valve more easy than the normal valve.
And if all the measures failed, you can go retrograde and then snaring the wire and go
Transeptal and going,
exactly. Yes.
So snaring the passing valve. So what you are trying now to pass the valve, are you using the normal wire or Terumo?
Straffen, mehr Straffen. Lass mal los. Gut, okay. Los. Steil.
مشكلته في ايه او كده؟
Wir können ja einfach auf Englisch kommentieren. Okay. So we're still. Okay, mach du.
We are hearing you good. So can you tell us what's the problem? You couldn't pass the surgical valve, or what's the problem now?
حاسس ان لازم حد فينا يقف يكلم الناس، بس يعني الناس قاعده مش عارفه ايه اللي بيحصل.
Wäre die erste Klappe, die ich nicht transzeptal, die ich nicht retrograd sondiert kriege. Da ist der Jet. Siehst du es? Guck mal da.
عشان الناس تستفيد نقف نشرح للناس بتعملوا ايه دلوقتي كده عشان كده سامعين ولا؟
So the problem now we're seeing the surgical valve, and this is the problem. Sometimes it's very difficult to passing the retrograde the surgical valve, and he can try. Dr. Yasser, what's your tips and tricks to passing the valve? We can change the catheter. We can change the wire. He is trying at first with Teflon wire, normal Teflon wire. He can change the wire to the Terumo drat. It's a hydrophilic wire. And Dr. Muhammad also gave a tip. We can do transeptal and going antegrade with the wire to the aorta, and steering this wire. It can also help to passing the valve. Dr. Yasser, do you have another tips and tricks?
No, we can do more basing, like rapid basing, like 120, 140, according to the hemodynamics of the patient. Especially when we have surgical prosthetic valve and degenerated valve, because the percentage of aortic regurgitation is high, so the flow always causing this wire to go away. So you do more basing to minimize the hemodynamics and can cross this valve.
So rapid basing 120 is another tips to passing the valve. The problem, the patient couldn't tolerate this rapid pacing 100. Some patients will not tolerate this for a long time. If anyone have another suggestion what we can do if we cannot pass a surgical valve retrograde? Any suggestion from audience?
You mentioned interatrial septal puncture.
Proctor connected.
Oh, now. We are still working hard on the retrograde passage of the prosthesis, which is tough. So,
Derek, you hear us?
yes, now we hear you. We
Very
didn't
good.
hear you for about 10 minutes, but now we're hearing you. We are still having a hard time in crossing the valve. Now bringing back again the Amplatz left 1. Den geraden Stahldraht. And we've tried several shapes of catheters. So we had an AL1, we had an AL2, we had Judkins right. We have tried several wires. Now going back to our standard setup using the Amplatz left 1 with a straight, soft-tipped steel wire. It appears as if the jet of the valve is a little bit eccentric, which makes it hard to get underneath the leaflets.
Do you think using Terumo wire would would be easier than the steerable wire?
I think in these very small anatomies, it is very difficult to cross. Sometimes an Amplatz multi-purpose or a Judkins right could be better than the Amplatz one. I don't know.
Right, Terumo. And it also didn't help. Und ein 12er Angio. Mach dir mal die Angio auf, bitte. Ist offen. Angio. So, this is the anatomy.
Maybe we can ask the panel about Dr. Yasser. If you have a breakable valve or non-breakable valve, this would change your strategy regarding coronary protection maneuvers.
Yeah, as he mentioned, we have to know the type of the valve, and there is some of applications now. You can do a selection for the previous valve and choose what is the optimum for this patient. If we have breakable valve, I think I used to do ballooning twice, one before and one after insertion of the other valve. I think it's very important to get the minimum gradient as we can. So I do pre-dilatation and then post-dilatation with bigger balloon.
Yes, but has this an effect regarding coronary obstruction if a breakable valve or non-breakable valve?
It's depend on the CT and how much the length of the leaflets of the previous valve, and it can obstruct the coronaries or not. So if the valve is breakable, the percentage of coronary obstruction is less than it's not breakable. It depends about the type of the valve too.
Do you have any comment?
I don't know. It will make difference if the valve. I will depend mainly on the virtual to the coronary. If it's less than 4 or more than 4, if I have enough space. But I don't know why it should be different between breakable valve. What's your experience?
I think there's a difference because if you have a breakable valve, the leaflets would go more towards the coronary ostium and the VTC would be lower. The final VTC.
So it will be more high risk.
Exactly.
But it depends on the height, Dr. Mohammed. It depends on the height of the
For sure,
Yeah.
for sure. But the VTC, I mean, you have many parameters: height, size of the coronary sinus,
Tough time.
and the VTC. And you have, if you have the VTC borderline and you have a breakable valve, you have to take into consideration that the distance would be smaller when you push the leaflets more toward the coronaries.
So you will be more to coronary
More cautious
protection if you were
regarding
doing
obstruction.
fracture, because the movement of leaflet to obstruct the coronary will be more high risk in the fracture
Exactly.
valve.
What's your opinion?
I fully agree. If you break the valve and the VTC is very short, it is of course a problem. But about the carotid protection, I don't use only when in basilica cases. I use protection, but in a normal valve-in-valve case, I don't use cerebral protection.
Here we see how difficult it's to pass the valve and the risk of embolization. It's not
Dr. Garhi, regarding your center, regarding cerebral protection
we're
device
doing
and
separate
valve,
in every valve and valve. We're doing separate. If the anatomy is suitable, so we're doing every valve and valve cerebral protection, because we know it's difficult to close the valve. We will do post dilatation in most of the cases. So we'll do in every case valve cerebral protection and valve.
Another important point is the position of the leaflets in the surgical valve. There are surgical valves with inner mounted leaflets and surgical valve with outer mounted leaflets. And the risk of coronary obstruction is as well more with the outer mounted leaflets.
Dr. Muhammad, how to solve this? Dr. Muhammad Saad, how to solve this? It's now like 15 minutes and there's no crossing.
I think the point with changing to Jatkin right would be a good idea. Changing with soft wire, Terumo wire would be a good idea. And if all the trials failed, I think transeptal puncture going from the left atrium to the left ventricle, retrograde, and then snailing the wire would be an option as well.
So what we've done now is that we've tried Amplatzer left 1, Amplatzer left 2, stiff and Terumo wires, Terumo and now we changed to a multi-purpose.
Do you think about Jatkin right?
Have a very good angulation.
Jatkin
We
right?
have also tried Jatkin's right.
Okay.
We have already tried extensively.
Can you do more rapid basing with straight Terumo wire on this caster? It may help, I think.
Can you see the jet? That's very impressive. So there's a very small but very...
There is a suggestion that you use fast pacing or rapid pacing to reduce the flow and getting better.
Okay, we will do. Pacer ready. Pacer 140 bitte. 140.
Can you tell us the LV function of this patient?
It's good.
So, Dr. Yasser, can you explain to audience why you suggest doing fast pacing to close the valve?
Pacer off.
So this degenerated valve has like a percentage of aortic regurg, so the wire every time getting away from the opening of the aortic valve. So with rapid pacing, you reduce the hemodynamics and the flow getting out. So the Terumo soft wire can go with the minimum flow through this valve with some rapid pacing. It may help one of the tips and tricks, but as Professor Muhammad mentioned, the last resort will be interatrial septal puncture, antegrade crossing, and then snaring of this wire.
Dr. Muhammad, why are you asking about the ejection fraction?
Because rapid pacing or fast
Rapid
pacing
pacing.
would impair the hemodynamics of the
Yes.
patient. This may result a problem with the procedure.
Yes. Right.
Darf ich mir mal die Angulation nochmal
The
anschauen?
ejection fraction is important. What the other factor will also compromise
As you see here, the rapid pacing getting the hemodynamics bad. So the pressure is like 50.
Okay, so you see the rapid
Just to
pacing.
explain, we have two pressures. The upper one is from the anesthetist, from the radial. Sometimes it's not the right one. And the lower one, which is higher, is directly from the ascending aorta. I think we have to depend on the lower one, not the upper one.
Muhammad, how many minutes you spend and then you change for the another tip?
We do our procedures in just local anesthesia. That's why procedural time is important. You have to decide rapidly changing the strategy.
So what we do now, we exchange the operator. After 20 minutes, we exchange the operator.
It's a good suggestion.
No, this is nice from you. Derek is one of the most experienced TAVI operators in Germany.
You know, we have what's
But
called.
nevertheless, we exchange.
We have what is called here.
Otherwise, we go transeptally. So at 30 minutes of fluoroscopy, we'll go transeptal. Testing the beginner's lock
Okay.
now. Which may help, obviously not very.
When we're working in cases like that, we have rule of 3 or rule of 5. Every operator in the room can try for 3 or 5 minutes, then we change till one succeeded to cross.
5 cases are different. Stahl, den Tomo. So let's see. So we have 4 operators in the room.
You need your glutter.
Call for the less experienced. It will be nice. Sometimes less experience is the one. In German, do you use anesthesiology for this type of patients? Which is this? You do use sedation or do you use anesthesia?
No, our strategy in our center, we use the fast track TAVI, and we do the patient primarily on local anesthesia. If the patient is not tolerating, we go further with sedation. Sedation anesthesia.
So even in valve, Dr. Muhammad, if you think that you will need a long time of rapid pacing.
This is a very good question. Even we do it even valve in valve. We have a special maneuver for post dilatation with 2 syringes and 3 operators should operate together. Should cooperate together with the post dilatation with 2 syringes. One pushes the first syringe, the second one elevates the pressure rapidly. The third one has the control of the others to minimize the period for fast pacing in the post dilatation phase. In your center, do you do pre-dilatation? If you have a breakable valve, you do the breaking the valve at first or implanting the valve at first?
After implanting the valve, as you strategy, we doing.
And you?
Same.
The same.
After implantation.
Dr. Yasser, do you think that the rate of stroke may be higher if you break the valve before implanting the TAVI valve?
No, I think it's not important to increase the rate or something like that. It depends on the distribution of the calcium and if the valve bicuspid or not, and if there is severe calcification or not. In case of valve in valve, I think we have to be very selective for which cases we will do cerebral protection. But I think it will not increase the rate. There is no statistically difference between the cases.
Yesterday, I heard Alex Abazid had a lecture regarding the cerebral protection. There is a new cerebral protection. It's called the embolizer. I don't know you need this. It's called the embolizer. It's like mesh, including covering the whole aorta. And this will prevent any leak going to all the vessels, not only one vessels, not like Sentinel. And then after you finish, you track this mesh down. Did you hear about this?
So it's like a TriGuard. We don't have clinical experience with this one. We use Sentinel. This problem, as you said, Professor Sobhi, that the Sentinel didn't protect the vertebral artery as the left side. So you still have instance of embolization, but we didn't have clinical experience with this TriGuard.
Maybe you summarize the cerebral protection device. We have two types, the filter type and the deflection systems. You are speaking about the deflection systems, and theoretically, they offer 100% protection because they cover all the ostia of the two carotids and the left subclavian, which is the origin of the vertebral artery. Then you have theoretically 100% protection. But I'll tell you my experience with this device. It's very difficult to have it co-opted on the ascending or on the aortic wall. It doesn't fit very well to cover all the three orifices. And the Sentinel works better even if you have only 70% protection, because the Sentinel system protects only two origins, one vertebral and two carotids, and the third vertebral, the left vertebral, is not protected. Even with this system, you have better protection for the three vessels than having the deflection device.
So, Dr. Muhammad, if you must do a transeptal puncture in this case, you will make it blind or with under TE guide?
We do always our transeptal puncture echo-guided.
We don't.
And in this case, I think, yeah. Yeah.
So, Dr. Yasser, you feel free to, you have a good experience with balloon valvoplasty and balloon mitral valvoplasty.
Yeah.
So you are feeling free to do
even in paravalvular leaks, when we have the maximum posterior or maximum anterior, we can depend on only the
anatomy,
the screen on the anatomy and fluoroscopy. So in 99% it works, and I can catch the whole. So it's perfect.
We are accustomed because of the mitral procedures, mitral clip, left atrial appendage closure, valve-in-valve mitral position. We have a very good experience with echo-guided transeptal puncture, which is safe as well for the patient for such a big procedure.
The problem, as you mentioned, that this is under local anesthesia. So you have to convert the patient for general anesthesia.
Exactly.
And do,
no, we don't. I see the problem in Germany because the reimbursement, it's not reimbursed. That's why we don't have to use IC too much.
So, Dr. Muhammad, where in the septum you will prefer to puncture to passing to the mitral valve, or it's?
This depends on the type of the procedure. If you are going to do mitral valvuloplasty, for example, if you are using the double balloon technique, you have to be lower. If you are going to use NV technique, you have to be higher. If you are going to do valve-in-valve mitral, you have to be lower again.
In this case, it's not.
In this case, I think it's not matter. Maybe midway would be a good option
to reduce the risk of the transeptal puncture. So, Dr. Yasser, how you do it without? Do you do angiography to see the right atrium, left atrium, or you do it without angiography? If you're doing transeptal in such a case, do you do angiography in the right atrium?
No, I depend on the fluoro only. On the fluoro, and I go for lateral view to see the aortic arch and then the vertebral column, and I go. Some operator do a pigtail in the aorta. I can do it or not. It depends on the anatomy of the patient, if there is any angulation to see exactly where is the aorta. But
so you will look in the LAO to see the posterior position of the transeptal.
I make this. Sorry, yes, sir. I make the NV type. The NV type, which is I do a pigtail in the aorta, and then I make a transverse line from the aorta, from the pigtail to the lateral wall, and then you make lining of the curve of the heart. And then the mid part of this line, that's a transverse line, you make a vertical line, and then 3-4 of the vertebra up. And this is the site, exact site, not in all cases. And then you go to the lateral, and then go straight, usually more posterior. This is another way. Sometimes if you have a huge right atrium, you have to do right and atrial angiography, and they make a levo phase, and this levo phase will show you the septum, and you put it in the screen. This is because we are a poor country, so we don't have it. This, as Yasser said, TE is not done. We did some cases in echo guided, but this is during pregnancy without it. We don't have the IC, as you see. So I think, but nowadays we have a 3D. So we are somewhat trained in some cases of the mitral. But if you are familiar with what you do before, it's, I think, easier. Nabil.
As long as transseptal.
So what we're doing now, so we have an eccentric jet, and the idea is now to use a pre-shaped Terumo to get underneath it. Let's see whether it works.
Okay.
So
Yes.
Dr. Nabil, you can.
For transseptal, first of all, we have to use two views. The posterior anterior view and lateral view is very important. And we decide the site of puncture. Usually I use a pigtail caster in the aorta as a landmark because the arrow of the needle should be directed posteriorly in the lateral view. And based on the type of balloon I'm going to use, if it is enoid, I have to puncture the septum at a higher level. If it's a multi-track or double balloon technique, I have to puncture it at a lower level. And we have a paper published with Dr. Ayman Saleh and myself. We did a lot of patients, pregnant ladies, TE guided, with a very little screen used in such ladies. TEE is very beneficial as regards transseptal puncture, even crossing the valve with the balloon. And we use saline to inflate the balloon instead of the contrast because the saline is very well visualized by the echo, then the contrast. And we published this in the American College of Cardiology, so it was great. But as Dr. Yasser mentioned, that in most of the cases, we don't use transesophageal echo. We have a very good experience to do it screen-based. Again, two views is very important, and the site of puncture based on the type of the balloon you are going to use. I'm going to ask about this case. Why not to use a transesophageal echo to visualize the orifice of the valve and to help to direct the wire, and which caster to use, whether a multi-purpose, an ambulance lift caster, or which one, or even the eyes? It can help in such case.
This is a very good question, Dr. Nabil. Maybe I cannot answer because we have very, very, very few cases which we cannot cross the valve. That's why the experience just to have to think about it and try to find a solution. Maybe can we suggest this for the team? Dirk, do you hear us?
Yeah, I hear you. So
do you think
tried now all shapes of catheters available?
Do you think using transesophageal echo?
All shapes of wires available?
Dr. Nabil Farag is asking if you can use transesophageal echo to localize the point of crossing
we start now. So we put a TOE probe in now.
But not for transeptal puncture, but for finding the opening of the valve. Do you think this can help?
Yeah, absolutely. That's what we're going to do right now.
Another question, as a last resort, for such case, if we fail to cross with different wires, is it possible to use a very stiff wire to perforate the cusps of the valve and to cross?
For sure. This is an option as well.
Yeah.
And transapical if the trans
might cause passage behind the valve.
Muhammad, you tried the BCI wire before?
No.
BCI wire.
I think the jet wouldn't allow the PCI wire to pass.
If you try to perforate the valve, it will be tricky. It will be difficult to pass the valve through the leaflet. And if you do a valvoplasty, you have a massive aortic regurg. So,
exactly. If you are going to do this, you have to be ready with the valve. You will have severe aortic insufficiency at once. But the strategy would be like this, penetrating the leaflets, opening a balloon, and then implanting the valve very rapidly because of the compromise of the hemodynamics.
So what's the plan?
There is another option to puncture the leaflets and then do a balloon dilatation and
It
then
is,
implant.
but
Like basilica.
sure, it's an option, but it's a very, very last option, I would say. Currently, we'll try the TOE option first, because using a very stiff wire might cause also perforation behind the valve.
This is a wise decision.
It's very traumatic, and I have no good experience with this. Yeah. Okay, so I would ask you to maybe pause the transmitting a little bit, because we will now sedate the patient deeply in order to put the TOE probe in, which will take us some time. So if you have anything else to continue with, we would be grateful currently. So we might be able to come back to you in about 15 to 20 minutes.
Just tell me when you pass the valve and we'll continue the live transmission.
Okay, perfect. Thank you.
Thank you. Good luck.
احنا عندنا 10 دقايق عايزين نستغل القصه دي. يعني معلش تسمحوا لي بس عشان انا شايف ناس كتير بتلعب في الموبايل مش معانا خالص يعني معلش سوري احنا بنكلم نفسنا احنا في ليسونز المفروض في الحاله دي. سيبك من الترانسميشن مش حلو دي مش قضيه. المشكله ان احنا دلوقتي بنشوف رامز بيه. احنا بنشوف حالات. احنا الاول بدينا التابي هو طبعا لازم نقف حداد على الاقل يمكن بري سنه يعني عشان عندنا 20 سنه. احنا في مصر بقى لنا 10 سنين دلوقتي عدد التابي زاد. عندنا اكسبيرينس كلنا بالتابي، انما الاكسبيرينس بتاعتنا فالف قليله. صح ولا غلط؟ يعني ما عندناش سيريز كبيره. فاحنا عايزين بصفتك بتشتغل كتير في تقولوا 1 2 3 4. 1 جالك فالف هل امتى تعمله؟ 2 السي تي يفرق ولا لا؟ 3 هتختار بالسي تي ايه الديفرنس بينها وبين الثانيه؟ 4 الوارز الاساسيه. 5 هل تعمل رابشرت ولا ما تعملش؟ السؤال اللي انا سالته لك الاول الموضه ليفلت موديفيكيشن. انا بقول لك من الاخر يعني ليفلت موديفيكيشن كل العالم بتشتغل عليه. يمكن الامريكان اكتر ناس بيشتغلوا دلوقتي على ليفلت موديفيكيشن. هل بيعملوها ازاي؟ البازيليكا ايه؟ يعني شويه تيبس اند تريكس كده بقى، لانها صراحه انا عايز اطلع في ال10 دقايق دول مجمع انا نفسي يعني.
تمام. طيب لو هنتكلم عن فالف ان فالف، فاول حاجه لازم هتيجي في بالك coronary obstruction. تاني حاجه الهيموداينامكس افتر فالف ان فالف. These are the most important differences between normal TAVI and valve in valve. For the coronary obstruction, you have extra measurements with the CT, which is called VTC, virtual valve to coronary ostium, number 1. Number 2, the height of the coronary ostium. Number 3, the size of sinus of valsalva. You have to combine all the 3 measurements to decide at the end, do I have a problem with this coronary ostium? Do I have to do coronary protection maneuvers, which are either Gemini or Basilica technique? This is the most important point, coronary protection. Valve in valve, 2 points, hemodynamics and coronary obstruction. Regarding the hemodynamics, you have to decide for the implanted valve. Is this a breakable valve? Can I break this valve to have more opening of the TAVI valve after that? Number 1. Number 2, how is the size of the implanted valve? If you have a small valve which is not breakable, then you will have a problem with the hemodynamics and patient prosthesis mismatch and the high gradient after implanting the TAVI valve. That's why if you have a breakable valve, I think taking a balloon expandable valve or self-expandable valve wouldn't be a big problem. If you cannot break this valve, then you can go for the next step, size of the implanted valve. A small one like this, 21 Hancock. If you implanted a sapien 20, it would be 20 millimeter sapien. 20 millimeter sapien in a normal patient has a problem with the hemodynamics. If you imagine if you implanted this valve as valve in valve, it wouldn't be fully open. That's why you will have a patient prosthesis mismatch after that. The patient who suffers with dyspnea, the valve leaflets would degenerate very rapidly. That's why in such a small anatomy, in a valve that cannot be broken, then you have to implant a supraannular valve. The importance of the hemodynamics of this patient would be putting a supraannular valve with good hemodynamics, with free mobility of the leaflets after that away from the surgically implanted valve. And this would improve the hemodynamics, number one. Number two, the degeneration of the TAVI leaflets would be not that rapid like implanting an intraannular valve. These are the more 2 points.
احمد فرح تعال. احمد ده انا كنت مشرف عليه في الماجستير والدكتوراه في اسكندريه، ودلوقتي هو بيشتغل بقاله 12 سنه في المانيا، بيعمل برضه تافي ومايترال وكل حاجه في الدنيا، بتوعنا بتوع المانيا. يلا احمد. محمد سعد المانيا ده نظامه. قول لي بقى التكات اللي انت تعرفها في سنتر تاني غيره.
يعني I'm not very experienced في الفالف and valve زي محمد، بس يعني هو قال تقريبا كل حاجه، يعني it's the same. I don't know، يعني هو زي ما قال محمد we use يعني self expanding او supraannular valves more than the Edwards. ممكن نسال محمد برضه، او يعني it's different، او محمد الجرح يا دكتور. الكمني I don't. البازيليكا I think البازيليكا is still limited in to يعني no too much centers do basilica in Germany or over the world. I don't know how many do use basilica.
احنا دايما بنشتغل، يعني احنا طبعا كل حسب كل الاكسبيرينس بتاع السنتر. احنا عندنا في السنتر بتاعنا مثلا بنشتغل يعني شيمني تكنيك. طبعا الاكسس بتاع الكورونري، عشان بس نتكلم ايه لما يكون عندنا في ريسك اوف كورونري اوبستراكشن، عندنا طريقتين. يا اما بنحط ستنت من الاورطه لغايه الاوستيوم بتاع الكورونري، الليفت كورونري او الرايت كورونري. وفي الحاله دي المشكله طبعا تكنيك اسهل ان انت تعمله اسهل، بس مشكلته ان الاكسسبيليتي بتاعت الكورونري بتبقى فيري ديفيكولت افتر ذيس بروسيجر. البروسيجر نفسه فيري يعني easy to do، بس difficult for patient. لو هو عندك young patient it's for the old patient but not for young patient. البازيليكا تكنيك عندنا في المانيا في سنترز قليله، يمكن اكتر 2 بيشتغلوا دكتور محمد صعب ومحمد عبد الوهاب في لايبتسش، يعني هما 2 سيرتن تقريبا في المانيا. في سنتر تاني بيشتغل او 3 اللي بيشتغلوها. احنا عندنا في السنتر بتاعنا ما عملناش قبل كده البازيليكا فكرتها ان انت بتعمل لاسيريشن، يعني بتبص اول حاجه محتاج جنرال انستيزيا، محتاج ان انت تبقى TE جايدد عشان تشوف بتعمل باسنج للليفلت بالظبط اللي هو بتاع الرايت كروني او الليفت كرونري. في ممكن تعمل دبل بازيليكا بس اتس فيري لونج بروسيجر. والبازيليكا فكرتها ان انت بتعمل لاسيريشن البيشنت بيبقى هيمودايناميك فيري انستيبل بعديها.
بس محمد I think دلوقتي انه النمبر اوف بازيليكا decreasing not increasing. ليه؟ الاكسبيرينس زائد انه السلكشن اوف ذا فالف دلوقتي يو كان افويد الكورونري اوبستراكشن. سو الحقيقه الحاجه الوحيده اللي احنا المفروض نتكلم عليها هو الشمني. انه الشمني انا شايف انه النمبر اوف كيسز اللي بتتعمل بالشمني should be very very limited for very high risk patient. لو انا عندي بيشنت عنده 70 ولا 75 سنه وعملت له شمني، البيشنت ده he will suffer. Okay, it's stent in the aorta، الكورونري اكسس بعد كده it's hell. سو يعني لو البيشنت ده انا هديله اوفر من 2 to do surgery او شمني I will send him for surgery.
يعني طالما الشمني can you comment what's your experience about coronary protection, shimney technique, basilica?
I can say that all the options are bad. The basilica is not a good option. I did some cases, but it is the double basilica is very difficult. Is for the sake of time. It is not good.
Can you explain the basilica? How are you doing basilica? How are you doing basilica? Can you explain for the audience the basilica?
The basilica is a procedure we cut the leaflet of both or one of the leaflet, and we retrofit the wire, and we snare the wire. First we retrofit the wire, and we perforate the leaflet, and we put a snare in the LVOT, and we catch the wire, and after we can catch break the leaflet, and after we put the valve, of course. But it is a very complicated procedure. I think it is not for double. The results are not good. for one could be. The chimney or the snorkeling is not good also. You could not assess after to the coronaries, and I think it's not good enough. I think that we in some time we could have a cut for the basilica. It is the name is a shortcut. It is like scissors for cutting the leaflets, and I think could be a good option. But I repeat, it is very bad. They are very bad options.
May I have the last word? For me, at least, I divide the patients in two groups. Very high risk of coronary obstruction and high risk for coronary obstruction. Very high risk of coronary obstruction, I go to basilica. High risk of coronary obstruction, I try to do the coronary protection device preparing for chimney. In about 90% of cases, you will not have to implant the stent. You will find that you are good, that there is the risk of coronary obstruction didn't happen, and then you take everything out and you don't have to do anything.
Just speaking with Ahmed, in the future for the United States, TAVR in TAVR. It's not only just to lacerate and then put in TAVR in the future. Anyway, I think we finished. It's a good lessons in spite of the difficulties. The difficult task. We are starting. I think maybe in the next year we have a lot of cases. Thank you very much for the speakers' audience.